So in the next 10 minutes, I'll try to summarize the accepted standard of care for glioblastoma following surgical resection. I was giving only 10 minutes, which is a big topic. Right. I'll have this all the time. Okay. As Dr. Larry said, more than 80 years ago, Dandy selected an aggressive approach trying to cure primary brain tumors, especially high-grade gliomas, with an aggressive hemispherectomy, trying to cure this patient. He concluded that this is not a surgical disease, not a purely surgical disease, and the tumor cannot be resected completely. And the survival did not improve with this significant resection. He had 4 patients, all of them survived less than 3 years. Over the years, we accumulated data from clinical observations and bench studies that this is an invasive, diffuse pathology which cannot be cured by surgery alone, even far away from the grossly inspected brain mass or the radiological appearance of the enhancing lesion. You still have some tumor invading far away from the mass itself. This led to the most recent classification or grading of the glioblastoma or astrocytic tumors, which is published in 2007 by WHO, showing that we have 4 grades of primary brain tumors ranging from 1 to 4. 1 is by definition, is the tumors which can be cured by surgical resection. From 2 to 4 is the tumors which is invasive and diffuse and cannot be cured by surgery alone, and it needs adjuvant treatment to try to stabilize and improve the outcome. Glioblastoma is a grade 4. This is the current NCCN guidelines. This is the most updated version, which was updated a few months ago. I would like to look at this red box, the guidelines and the accepted international standard of care for glioblastoma. It's maximum safe resection with a plus or minus BCNU wafer. I'm going to come to this later in my presentation. This should be followed by adjuvant treatment. The adjuvant treatment is radiation and chemotherapy concurrent for 6 weeks, followed by temozolomide maintenance. I think this is going to be changed due to the most recent publication, which I'm going to discuss. Following resection, if you have a progressive disease, if you can resect again with the safe resection, you should do it again, and then you plus or minus implantation of the BCNU wafers. Or if it's unresectable, then you go to the, you have 4 options: palliative care versus systemic chemotherapy, consider re-radiation, or alternative electrical field therapy. Now, how did we reach this conclusion? The first evidence that radiation improved the survival and the outcome of high-grade gliomas within 1978 showed significant difference in the group receiving radiation versus chemotherapy, which was BCNU at that time. It improved from 14 weeks to 35 months. This was significant clinically and statistically. So since then, the radiation treatment was introduced as a standard of care for all high-grade gliomas. Despite this data was done, this study was done in anaplastic astrocytoma, but this was translated to glioblastoma in the clinical practice. Over 40 years, nothing exciting happening. In the late 1990s, the group, North American group, published a randomized study about Glidel, the BCNU wafer, which is implanted after the surgical resection of glioblastomas or high-grade gliomas, showing a significant difference. So they have 2 arms. It was randomized, double-blinded, comparing the wafer after surgical resection plus radiation versus radiation alone. Keep in mind that this study did not include temozolomide as a maintenance treatment, so they compared radiation or radiation plus wafer, and it shows significant improvement from 11 months to 13 months. This was significant, and you see here the lines is not crossing when you discuss the survival. Again, progression-free survival shows crossing in the end. So currently the FDA, the European and the American FDA approved wafer as in the Glidel wafer as a newly diagnosed GBM, as an adjuvant treatment, and recurrent glioblastoma multiforme as an adjunct to surgery. Then comes the big study, which is one of the most famous studies, the STOOP study in 2005, followed by the 2009 5 years follow-up, showing a significant improvement comparing chemotherapy in the form of temozolomide with radiation compared to radiation alone, showing a 2-month difference in survival at a year. And then the more significant results was that a group of patients will survive for 5 years, reaching 10% of the overall population, which is significant. Notice the improvement in survival overall in both groups, radiation versus radiotherapy plus temozolomide, compared to the study we showed in 1978. So there is almost 100% improvement in survival. Temozolomide, this is the standard of care, which is accepted internationally almost in all institutions. After surgical resection, the patient received radiation and chemotherapy in the form of temozolomide for 6 weeks. The radiation dose is 60 gray, 2 grays per session, 30 sessions. That is followed by 6 cycles of temozolomide on a monthly basis. This can be extended to 1 year, depends on the patient and the tumor progression. Why temozolomide? Well, this was a big thing because temozolomide had a pharmacokinetics behavior which is better than the other cytotoxic agents. It can cross the blood-brain barrier. It's an oral chemotherapy. The side effect profile is much, much better compared to other traditional chemotherapies. Then in early 2000, 2005 comes the Avastin. The Avastin was a big thing. It was like the magic drug. No one saw this type of improvement when you give chemotherapy or any type of medications to primary brain tumors. On the left hand, you can see a left side brainstem high-grade enhancing glioma, which was confirmed by biopsy, and the difference between the two images is only 12 weeks. So after 3 injections of Avastin, we see this improvement. Everyone thought that this is going to be the big new thing, and the FDA approved Avastin in an accelerated fashion in 2009 because the patients were pushing for it, and the phase 2 trials showed significant radiological response. So the Avastin was approved at that time without going to a phase 3 trials for recurrent GBM, which was a big thing. Everyone thought Avastin is the new change. Avastin it's a monoclonal antibodies, which is a targeted chemotherapy against VEGF, which inhibit angiogenesis leading to cell death. After this approval, two big extensive studies were launched, giving Avastin upfront with the standard of care. That means the patient will have a surgical resection that will be followed by radiation and chemotherapy and Avastin on top of the temozolomide and radiation. 2 huge studies were launched over 5 years, huge numbers. Unfortunately, these studies did not translate in a significant improvement in survival. The primary endpoint for these studies was survival, which did not show an improvement. But look at the numbers: 15 versus 16, 16.8 versus 16.7. Again, these numbers, if you compare to the study in 1978 giving radiation alone, we already improved the survival by 200%. Again, looking at the secondary endpoint, we saw some progression-free survival improvement, but they start crossing again in both studies. So that did not lead to approval of the Avastin as a primary adjuvant treatment following resection. It's only approved in recurrence disease. Now the big thing, this is new, this was published 2 months ago, tumor treating field. Tumor treating field depends on its philosophy, applying electrical alternating pulse through the brain, non-invasive method. It alternates the cell division leading to cell cytosis and cell death. The study, which was just published in 2015, was planned to go over 5 years, more than 700 patients. It's called AF14. Large, multinational, open-label randomized phase 3 studies, well conducted, showed a significant difference in progression-free survival from 4 to 7, comparing the standard of care or standard of care plus, it's called Optune, that's the medical device. And again, this was translated to a survival improvement from 15.6 to 20. We rarely see this type of clinically and statistically significant results with chemotherapy or treatment for primary brain tumors. So this was a big thing. The study was terminated because of the significant results. And even looking at both curves, this type of curve, non-crossing curve, comparing 2 arms in primary brain tumors is really rare. So this led to approval of the device in the FDA directly once the study was terminated. So this is from the FDA website. It's indicated for tumor with a supratentorial GBM after resection with combination of chemotherapy and radiation. It's also indicated for progressive disease, but they have a note that it's not intended to be used as a substitution for standard treatment, but rather an adjunct therapy. So giving this data and these results, I think the new version of the NCCN guidelines will change. I think they'll do this like in the near future. The Optune or the TTF treatment should be added here as a standard of care as an adjuvant therapy after surgical resection. Just to highlight the other treatment which is currently used or accepted as an alternative to current standard of care in recurrent disease, we have temozolomide, Avastin is still there, Avastin plus other chemotherapies, temozolomide, BCNU, CCNU, PCV, cyclophosphamide, and other platinum-based regimen. This all can be used as a second line. All these drugs showed some improvement, but wasn't translated as a significant clinical change in outcome. Now in 2016, the patient is confused, the physician is confused. We have vaccines, immunotherapy, antiviral treatment, gene therapy, ketogenic diet. traditional medicine, alternative medicine, weed here in special medicine, MGMT methylation, the mutation, my gene profile. We have patients coming to the US with a test done outside. They pay $1,000. They have the full genome of the cancer analyzed and coming with like 50 mutations, ask us for specific treatment. How can we deal with this? Studies, clinical trials. If you go to the website clinicaltrial.gov, you're going to see more than 301 studies conducted for glioblastoma. It is recruiting and currently recruiting. If you type high-grade glioma, it's still the final slide. So more than 400 studies currently running for high-grade glioma. Unfortunately, none of these is running in Saudi. In our region, I went through some of them. I didn't see anything. I'm not aware of any institution in Saudi participating in these high-grade glioma studies. In conclusion, it's not a surgical disease. We have new treatment which should be included in our standard of care. We should be involved more in clinical trials for GBM patients.
Thank you. Thank you very much.